really excited to have Mario Schlosser, the co-founder and CEO of Oscar Health here. And Oscar, we've been working quite a bit with them at Cornell Tech. There are a number of Cornell Tech alumni who are working at Oscar. And in fact, I just saw a current student who has an offer from Oscar, so of course he's going to do the right thing. No, I'm just kidding. So anyway, really excited to hear a little bit from Mario. Oscar's really been trying to do healthcare right. And in this country, there's a lot of room for making healthcare just better, much less right. So I think it'll be great to hear from him. And I always really enjoy hearing Scarlett's questions. So having Scarlett interview him is really a treat. So no further ado.
Thank you. Happy New Year, everyone. Thank you for joining us for the first monthly panel for the Cornell Tech at Bloomberg Speaker Series. We have with us Mario Schlosser, co-founder and CEO of Oscar Health. And Mario, as we consider your background, your journey to entrepreneur, your credentials are impressive even before you look into Oscar Health. You were a senior investment analyst at Bridgewater, the secretive hedge fund run by Ray Dalio. You're a consultant for McKinsey. You wrote and co-authored 10 computer science publications as a visiting scholar at Stanford. You somehow found time during all of this to found the largest social gaming company in Latin America. So my question to you is, which of these different experiences have you drawn upon the most in forming your vision of healthcare insurance in the US? Or does it come down to the fact that you're from Germany and you've seen better systems?
Yeah. It's probably all of the above and a lot's the latter. My sister is a nurse in Germany, a pediatric ICU nurse. My mother actually was the same. And so I had some notion of what healthcare maybe could look like and doesn't always look like in the US. I think the experience I had the last 6 years now actually, that's most led me to start the company with Josh Kushner was the other co-founder, was the birth of my 2 kids. So while all this stuff is happening, we had a 4-year-old and a 5-year-old, now 4-year-old and 5-year-olds. By the way, insider tip, if you ever find yourself wanting to start a health insurance company, have kids at the same time. They're very great demo subjects for testing out how this all works. And really in 2012, early 2012, when my wife was 3 months pregnant and we were trying to navigate how this would all work, how much this would cost us.
Wait, before you get into that, you were in between jobs at the time, right?
That's true. In fact, that social gaming company that, by the way, Josh and I also had founded a couple of years before that, had hit, I would say, the same turbulence that many other social game companies at the time went through. And as a founder of it, I got fired by the board. And so I actually got thrown out of the company in February 2012. And Josh and I kind of regrouped in New York. This was mostly in Buenos Aires, Sao Paulo, Latin America the games were very popular. And we, wife pregnant, we were talking about what we should do next. And then Josh actually said we should start a health insurance company. I was sort of like gearing up for a year or a couple of years of mostly trying to hit singles as opposed to trying to go for a big home run and do something very complex, but coupled with the experience of, at the time, going through the pregnancy or watching someone go through the pregnancy, it seemed like a good idea to at least try.
So what kind of insurance did you have? If you were in between jobs, your wife was in academia, what kind of coverage did you have? Because at some point you were outraged into action. Right.
I think I had United Healthcare at the time, one of the big 5 insurance companies, the biggest one actually in the US. And here's where the problem started. I didn't know that I had United in a sense. There was an ID card somewhere in my pockets. It was probably mostly rubbed off, and stuff like that. And it wasn't really my first thoughts to think about the health insurance company when it came to how do I navigate the system in front of me. That's not really what you think of first. You go and ask your friends maybe, you go and Google it, and you kind of go through those usual channels. You don't think of necessarily engaging your insurance company, and that felt like a big gap in the way the system works. Experience then was, what would this cost me? How much, which pediatrician would I go and try to find to now take care of the kid once he's born? And those things I couldn't really answer even once I realized United, I maybe could just give him a call. The other thing that then happened was, we were on COBRA, which is basically you leave your employer, and you keep paying out of your own pockets for a while the premiums for the insurance company.
Right.
That's, I think, a thing that Bill Clinton introduced in the 90s as an option for...
So you don't lose your insurance
don't lose
coverage.
insurance for a while, for like
Yeah.
18 months or so, something like that. And my wife, who, as you mentioned, was a postdoc at Columbia University at the time, she finished her postdoc just before Noah, our kid, came, and she was making, I think, $40,000 a year or so as a postdoc, and then went also on COBRA on her own rates and realized then that her COBRA rate was going to be $2,000 a month. And so if you do the math, all this time that she was at Columbia, 5 years or so doing a postdoc, she was earning $40,000 in take-home pay. And behind the scenes, Columbia, her employer was paying $25,000 or so to the healthcare system for clearly sort of like overpriced insurance, for probably too rich of a set of benefits, for network designs she would have probably opted out of. She would have rather said, give me insurance coverage, give me the right kind of coverage, and let me take half of this amount of money you're paying behind my back to somebody else home and I do my own, healthcare with it.
And along the way, during 2012, the Supreme Court also upheld the individual mandates. So that kind of created an opening for you to rethink about what you might do with health insurance.
That's the, part of every, I think, company's founding story. A company that makes it to a certain level, I think, in its evolution is a degree of totally dumb luck. And so in our case, I think the fact that Josh and I talked about this in March 2012 for the first time at the first coffee in New York, what do we do next, insurance? And that we then a few months later realized there is a new market emerging, the individual insurance market, which really didn't exist almost before. That was complete coincidence. And the way this really went was that when Josh said we start an insurance company, I literally told him, I said, go and hire McKinsey. This is the kind of thing where I don't know what the differentiation would be. I don't know anything about insurance, really. I know it kind of sucks for everybody I know. But what would you do differently? It seemed like a thing where you got to put the pieces together in a very tight, operationally orchestrated way. And, McKinsey, whatever, would write you down how that would work, and you could maybe found it. But I looked into it a little bit and read a bunch of papers and whatever. And again, realized that the market for individuals in New York State buying insurance out of their own pockets in 2012 was something like 20,000 people. So this entire state, almost nobody was paying out of their own pocket for insurance. And the reason was that you actually pretty much couldn't do it. The way the market worked was that you would either get underwritten against, meaning you could not buy insurance because you stubbed your toe at some point 10 years ago, literally at that level. And there's an insurance company in Minnesota, I think, that would give you insurance if you had a kid born through vaginal birth, but not if you had a kid born through C-section. Because the probability you get another C-section...
And that's something you won't know until the birth comes.
It's crazy, right? But that's the way the market worked at the time. So either you got underwritten against, or you had a sky-high premium that you couldn't really afford to pay for. And so in 2012, in middle 2012, the Supreme Court basically upheld what's now called Obamacare, right? The Affordable Care Act. And we realized, wow, overnight in a city like New York, or in a state like, downstate New York, basically, about 1 million people would come into this market who didn't have insurance before. Anything from, freelance designers to dog walkers to restaurant workers to university lecturers who just didn't get insurance through the government or through their employer. They would buy it, and we would be at a level playing field vis-a-vis the incumbents, because incumbent insurance companies don't really sell insurance to individuals, which I knew from the crappy ID card app from United. So
it created an opening for you. So, okay, walk us through then how your wife's experience, your experience, would be different today if she were insured under Oscar when she was pregnant. How would she be treated? What kind of services would she have at her disposal? How much interaction would she have with the insurance company, with doctors?
Yeah, it's a whole bunch of different things. So first of all, we would know much more quickly that you are going through pregnancy. We pair every member of Oscar up with an internal concierge team. It's 4 people in our customer service staff, and one of those 4 people is a nurse. And whenever you interact with Oscar, whether it's through chats or calling us or whatever, the same 4 people will get back to you. So from the beginning, you build up a level of trust with these 4 people that you wouldn't have if you called United and end up somewhere, probably not even in the US, frankly. And so that concierge team gets a real-time data feeds of anything we would be able to know about you from how you interact with the healthcare system that we think is important in helping you with. And so in this case, the first time she'd gone to an OBGYN and that person would have diagnosed her with, okay, you're pregnant, we would have been able to pick up on that signal, and the concierge team nurse would have reached out to her and said, great, you go through pregnancy, best of luck, and here's how I can help you with all of this. Here's how many ultrasounds you ought to have. Do you have a pediatrician in mind? Do you like your OBGYN? Can we help you with anything along those lines? So that's kind of, from the very beginning, a very different level of engagement. We had a case, a couple of months ago that I remember talking to a concierge nurse about, where a member in another state was going through pregnancy, was all going well, but somewhere through pregnancy, the woman developed a, kind of pregnancy-type depression, mental health issue, basically. And, the nurse had the relationship with her to have her open up about that and could then help her get the right help for that. Whereas otherwise, whether the busy OBGYN would have been able to help and connect the dots on that is sort of oftentimes an open question.
So it's personalized care, it's customized care, it's high touch.
Exactly.
At the same time, you use what you call a curated narrow network. I kind of liken it to a really well-run HMO rather than a broad network. My question to you, though, is how do you sell people on the idea that narrow is good when everyone prizes flexibility and options? I mean, everyone wants as many choices as possible. How do you tell them, no, actually, we're going to give you this range of choices in terms of doctors and services, and you're going to like it more?
Yeah, that has a whole bunch of different aspects in the answer, but let me talk about, I'd say, personal experience and macroeconomics, okay, those two and the difference on the spectrum. Personal experience, maybe starting there, the pediatrician we then went to, we found him because a couple living in the same apartment building who was pregnant around the same time as my wife was, kind of randomly, we met them in the elevator, realized, oh, you're pregnant as well, okay, bonded over that a little bit.
There's that dumb luck angle again.
Exactly, and asked them, where are you going to take your kids once he's born? And they said, this guy, and we're like, great, that's going to be our pediatrician as well. I mean, that was the strength of the quantitatively data-driven scientific, process we went through basically to find this physician. And we actually were lucky in that one, so that's not a great example for how this can go wrong. But in the end, this is a I think very common experience. The scientific evidence, oftentimes, of work on what constitutes physician quality is still fairly thin. And it's fairly thin because nobody's really asked as much for it in the system. And as one result, healthcare is the only industry I know of where the way the sort of like market forces work, there is nothing that forces cost and quality into line. And you have you see this everywhere you go. There's a study from our regulators in New York that's basically a couple of years ago asked all the hospitals in New York to compile claims information, give it anonymized to the regulators, and then look at how effectively and efficiently are these hospitals treating patients and how expensive is it? And it just downstate New York, so not even across the state, whatever, just downstate New York, which is basically Long Island, New York City, and so on, the lowest cost hospital on a risk-adjusted, member demographic adjusted basis is at a cost index of 0.58, and the highest one at 1.82. Okay, so a factor of 3 in costs. Even between the highest quintile and the second highest quintile of costs, there's still a 30% cost difference.
Wow.
How these hospitals deliver care. Then you look at how, at least on a hospital basis, there is some quality metrics compiled by the government, by certain not-for-profits and so on, how those correlate with the costs that's underlying this. And only about 30% of all indicators for quality are even correlated positively with where the hospitals are in those quintiles. And so that also means if you look between the fourth and the fifth quintile of costs, 30% cost difference, no difference in quality, basically. And so we looked at this and said, that's a crazy situation to be in. We're spending about 18% of GDP on healthcare. The next highest costs country in the OECD, the Club of Rich Countries, spends about 11%. That's Switzerland. That's a very rich country. I don't know if you've been there, but it's very nice and everything. They've got universal coverage, not a single payer system. It's all private hospitals and private insurance companies, but universal coverage. They kind of make that work that way. Ironically, it's actually Paul Ryan's favorite healthcare system. So there's something to be learned from that, even for Republicans. somehow, we are not able, even though we spend a fifth of our income in the end, to build a system here where higher costs somehow maybe means higher quality, or where there's even any relationship there. And that's where we now said, given how unscientific oftentimes our discovery processes are for finding healthcare, again, my personal story and many other things we've seen, given how really outrageous the cost of the healthcare system is in the US and how just bad it is from an economic perspective and even a moral perspective to have high costs providers get away with it in a sense, not delivering better costs but just charging up. How can we combine those two insights to what's building what we think is a better model? And that is for us building selective networks. It's basically going in and saying, in a place like New York City, who is a hospital system that wants to deliver high-value healthcare, that can do everything, right? It's not about when you have cancer, you can't go to the best doctor, but that also wants to deliver this at really good unit costs. And then how can we build physician groups and practices around that, so all the referral patterns work out, so we can prove that at any point in time we can get you in time to a physician when something happens. We can oftentimes schedule appointments more quickly than the incumbent insurance companies. And so we put this together. And that becomes a model that puts pressure on unit costs and therefore can deliver better cost outcomes. And also we really think, because again, quality, cost don't correlate, we can get you to the highest quality physicians there at a better cost outcome.
Okay, my question to you then is, how important are brand names in healthcare? Because if, for instance, you're in New York, you have cancer, everyone wants to go to Sloan Kettering, right? Because that's the name that you always hear of. I look at who you're partners with in these different states. In Ohio, it's with the Cleveland Clinic. Yeah. In Nashville, it's with Humana. In California, in the Bay Area, it's UCSF. Here in New York, it's Mount Sinai. Does that matter to your customers, to your members, who the network is? Or do they trust that you've curated the networks to the point where, even though they haven't heard of this doctor or heard of this organization, this healthcare organization, they believe that they're going to get the best treatment?
So I really think we are at the beginning of this journey. I think that if you look 10 years out, it's very evident to me that almost all of US healthcare will have to reorient itself in this more value-driven comparative basis. As an example, again, if you look at, there was a recent study from the RAND Corporation on employers in Indiana, self-insured employers. Their outpatient hospital rates are on average 358% of Medicare. That's a way of measuring costs. Ours are around 200%. So right there, there's a very big cost difference there. Warren Buffett said just recently again, I don't need tax reform. If you look at kind of, again, corporate taxes on corporate profits as percent of GDP, it's something like 2%. So you knock half of that off as maybe a percent. That's you sort of like give US businesses in increased competitiveness vis-a-vis their counterparts in other countries. Healthcare, 18% to 11%. So you knock half of that off, you're 3.5% better in terms of competitiveness. We're gonna have to do something about bending that cost curve. The only way to really get at that is through unit costs in healthcare value chains. So almost all of the system will move towards that. And we can talk about our Cleveland deal as a good example of that in a second. But it is a journey. Not everybody will buy into this. For example, for us, in the first 3 years of Oscar in New York City, we had no chance of building our own hospital system, our own hospital network and doctor network. We had no members. We had, early on no license even, and a bunch of good ideas and smart people, basically. The idea that we could go in and negotiate with the CEO of Mount Sinai a good healthcare deal was preposterous. So for the first 3 years, we rented a physician hospital network. That works in healthcare. There's companies that lease out their own contracts that they built with hospitals, providers, and so on. So we then, in 2017, for the first time launched this Sinai, Montefiore in the Bronx and Westchester, and the Catholic systems on Long Island's type hospital and physician network that we now have. And in that transition, about 2/3 of the members we have stuck with Oscar, and about 1/3 left.
Okay.
So right there, you see it's not for everybody. When we survey the members who left at a factor of 3.5 to 1, people who left told us, I'm leaving because a physician of mine is leaving. versus a hospital brand that I like is leaving. So this is really almost all about the physician, which again, I think to me is very hopeful, because the physician isn't where the cost equation in healthcare is broken. It's the sort of like the facilities, the emergency rooms, the imaging centers and stuff like that. So if you can, and this is basically what we're doing, if you can build a network where you have fewer hospitals, but we can quantitatively show that yes, if you get cancer episodes, you are complex chronic patients, you can still get world-class care, which we can show. We know this all from government scores and other studies we do and so on. And we can then tell you that the person who's really going to take care of you is, on the one hand, your concierge team, your Oscar concierge team. On the other hand, the Oscar teledoctor. We have a staff of teledoctors who you can chat with and talk to and so on. And then a very highly curated set of physicians who we then also often have appointment scheduling integrations with, EHR integrations with, and things like that. That becomes a very good system. And then what we still do, of course, is when we authorize and go through with members complex conditions, then we look at what works best for that particular condition, and we have members who are across the country in facilities where some very specific treatment is needed, and we then make sure the members get there, get flown out there, get the single case agreement that's needed for that, et cetera.
So one thing that you've done, and I know a lot of people in our audience are interested in, is the tech and disruption part of your business model. You've made the case for why cost and quality in healthcare don't align and how they haven't for years. But you're using the same existing healthcare data that everyone else in the industry has access to. What you're doing differently, though, is thinking about it in a different way. You're slicing and dicing it differently. You've got a doctor on staff to reorganize it to make it more clinically relevant. Talk to us about what you've done there and how that's changed the outcome.
Yeah. So the kind of two reasons that I got excited about Oscar and the idea of starting an insurance company back in those days was, on the one hand, of course, user experience and all the stuff I was pissed off about. But as a computer scientist, the two things that appealed to me were the fact that the insurer has a incredible data visibility in the healthcare system, unlike almost any other actor in healthcare. If you're a physician, you see the drugs that you prescribe, not that the other physicians prescribe. If you're a hospital, you don't see a member until he or she walks into the ER. And oftentimes you can't get in touch again when the person leaves the ER and things like that. The insurer sees all of this because at the end of the day, somehow the bill's got to get to the insurance company. So that was one thing, data visibility, fantastic. From actually running these games, you asked about how I connect the experience up. I knew that knowing if you prefer a blue cow or a red cow on your farm, those were the kind of games we had, isn't enough. You got to also entice people to actually do something about that. And so it is important that we can give financial incentives and change incentives, and the insurance company can do that because it controls the flow of money throughout the healthcare system. If you really think about this, nobody in the healthcare system has a business model where they are better off when the healthcare costs come down. Not the hospital, not the physician, not the drug company, not the imaging centers, really only the insurance company. We oftentimes think that the insurance company is antagonistic to the member in a sense, because the way they get at that equation is by denying stuff.
Right, there's that tension.
Exactly, or not answering your phone calls, and thereby implicitly denying, basically. But if you really think about it, the economics are aligned. If you stay healthy, if you for the right reason go into the wrong kind of location of care and this costs you money and the insurer helps you avoid that, right? Kids crying at night, don't go to the ER, call our teledoctor, for example. That's a good alignment in the end on the economic sides. And so this idea of using data and building incentives around it in Oscar. Sorry, that was a long precursor to what we're doing with data as a story there.
You're making billing codes more transparent. Please say that.
Exactly. Now, what are we doing with data? Exactly. What are we doing with data? Again, kind of to take another step back, the problem with data in healthcare is that the entire piping of the system was built for payment purposes and nothing else.
Yep.
Because everybody in healthcare earns fee for service, because the hospital makes money when you walk into the ER, when the imaging center makes a study, whatever. Nobody really had to ever add clinical payloads to the data going back and forth in the healthcare system. It's all about pay me for this thing that I did, and maybe for this diagnosis code. That's what the data in healthcare is. that's very sparse data. Just a recent study that I just read about yesterday, in the UK, you tried a machine learning classifier on discovering melanoma in like photos of skin or whatever. Best doctors had sensitivity of 65%, and you trained a neural network and it went up to 71%. A very small improvement because the underlying data was crap. And literally that's the problem in healthcare. It's only built for payment purposes, not for anything else. So what do we do with that then? We realized kind of early on that the biggest step forward in data is not so much necessarily more comprehensive clinical data. You can oftentimes find out more in conversation with a member or a physician what's going on with a particular person than you have encoded medical records or whatever else, but it's about the real-time nature of it. The more we can know in real time when something's happening with you and then engage on that with you, that avoids the big mistakes in healthcare. That sort of like helps you go back on the right path in healthcare and things like that. And so in New York, for example, we know for almost all the emergency rooms in real time when you are in the emergency room. And again, your concierge team would reach out to you and say, and we see you in the ER, can we help you with that? Probably not right while you're in the ER, but then making sure that whatever the doctor tells you, you understand. We get you an appointment as a follow-up. We remind you got to go in. We make sure you pick up the drug and things like that. So the real-time nature is very important. There is a wide field of data. So for the technologists in the room, it's amazing how I'd say not well thought out the ontologies are in healthcare. And here's what I mean with that. So when you go on the typical insurance company website, and oftentimes even hospital websites, and you kind of click on that drop-down field that says, here are the physicians that we have, and you look at that.
The departments and all that.
Exactly, all that stuff, and you count how many specialties they distinguish. It's usually between 70 and 100 or so. When we look at what you really need to know to get the right disease and issue with a member to the right physician, you have to have about 325 or so.
Wow.
And so we have those internally. We basically rebuild that, and then we scan the physicians, what exactly they do, and we then get you to the right person. All the way to, again, personal example, my kids both had their tonsils taken out, like snored a lot of nights and stuff like that, and eventually had tonsils taken out. I had my concierge team look for the physician who would be able to do that in the best possible way. And I asked some pediatrician as well. And you got when you ask people, you get the usual stuff of, go to this department leader, go to this guy who runs this pediatric department, whatever here, or go to this guy, he was my buddy in medical school. That's also like an oftentimes heard thing. When we looked at the data again, I ended up going to the guy in New York who did 1,000 tonsillectomies in the last 18 months. It's a guy named Dr. Shinhar, if you care to know. Literally the single most frequent tonsillectomists, or whatever you call it, in New York. And he's a machine doing that. He does 5 a day, basically. And if there's one sort of like known correlation in healthcare between quality and some other data element, it's actually quantity of procedure or frequency of procedure. There is a correlation there. This guy knows how to do it, and he will just do it over and over again and be good at that.
Right.
And that's how one way we use information. So real time, finding physicians and things like that.
Great example. Let's talk a little bit about the situation now, the context now, because obviously the Republican-led Congress repealed the individual mandate at the end of last year. What changes have you made to what you do? Has it changed anything?
The last, I was going to say the last 18 months have been even more interesting than usual. I actually think it goes further back. I'd say the last 3 or 4 years since the ACA launch have been wild for the following reason. When you have a new insurance markets launch, it's always chaos at the beginning.
Yeah.
If you go 15, 20 years back and Medicare Advantage was launched, which now today is the most profitable insurance market for all incumbent health insurers, it was also a total mess. There was membership coming in, went down again, insurers lost money, went bankrupt and all that kind of stuff. And then finally the market settled in.
How many years later?
4 or 5 years later.
Okay.
It took about, I think 2005 was the dip in enrollments, then it started coming back up again in 2001 or so, I think is when things started growing for real. So 4 to 5 years later, basically, it started stabilizing. And the biggest reason is that you just don't know early on how to price the risk in the markets. In the ACA did something, did a lot of very good things, very smart things if we lived in different times, both Republicans and Democrats would be able to agree on. In fact, One guy from the Heritage Foundation literally said this once to me. I was at some kind of roundtable. That guy was there as well. And he basically said, yeah, we would have never gotten away with putting in high deductible plans, if it hadn't been for the Democrats doing the ACA. Because Republicans and many economists think deductibles are a good thing. And I actually tend to agree with that if you manage it properly. Like we give people free telemedicine, for example. So even though you have a deductible, the routine care oftentimes is free. But anyhow, that's how sort of like the landscape looks. But early on, you don't know who's going to show up. And again, smart things the ACA did is that they allowed everybody to come in and get the same price. And that is a good thing for overall risk pools and insurance markets, but it takes a while to stabilize. So until 2016, these markets were very difficult to navigate. And even now they are. But until 16, insurers had to kind of guess where the risk is, understand the way the programs work. There's all kinds of complicated transfer formulas and pricing and in there and whatever that we had to kind of figure out how this works. In October 2015, about 6 months after we priced our plans for 2016, okay, I get a call, cheerful from, at the time, Andy Slavitt, the guy who runs CMS, our federal regulator, and says, hey, Mario, and it's always, you get a scare when the regulators call you, basically. He's like, I just want to let you know something. This program called the Risk Corridor program, where Oscar is owed $200 million under, it unfortunately will not be funded. You'll get 2% of that. So suddenly we were short $200 million or something like that. So these things all happened even before there was an election. And that really meant that no matter who had come into power in 2017, this market needed fixing and stabilization. And now, in many ways, I think it certainly was not helpful to have all this sort of like back and forth and the rhetoric around we want to kill this market, it's not a good market and stuff like that. I really do think that in the end, what everybody on Capitol Hill understands, or everybody in DC understands, is that it's a very, very bad idea, immoral, obviously, but also bad for elections, frankly, to throw 15 million people who have gotten health insurance through the ACA basically back on the streets. It's bad for even the hospitals who now get more funding through these kind of programs. And so we always thought that wouldn't quite happen. And if you actually look at the way our regulators dealt with us, again, the administration in HHS and CMS, it was always a lot more pragmatic and to the point, and sort of like saying, we know we got to make this thing, we know we got to somehow make this thing work. We can talk about the mechanisms, but we got to make it work somehow. And so I think that's kind of what happens. Even the CSRD funding at the end of last year, one thing that got a lot of press, in the end, the way it was done and signaled and sort of like presupposed and prepared wasn't a negative for the markets and for the insurance companies and therefore for the members as well. So we got to make sure that stays that way.
So like so many other things, the bark is worse than the bite, and there's deep pragmatism at the end of the day. You talked about some money owed to you. In the first half of 2017, I believe Oscar lost $58 million. Your revenue has been increasing because you have been expanding. I believe this year you're expanding to 6 states from 3 states. Presumably you kept losing money in the second half of last year as well. How patient are your investors? We're talking about Google Capital, Fidelity, Founders Fund, Peter Thiel for that matter. I mean, if it takes 4 to 5 years to find some kind of stabilization, as you mentioned earlier, how long are they willing to wait?
So I think they are. The good thing about Oscar is it's a very clear business model. We didn't have to reinvent how to monetize chat applications or whatever. It's very, very straightforward. There's a premium coming in, there's a medical loss ratio going out, and we have an administrative overheads. That's it. Nothing else, basically. And so what we were always able to show to the investors, and the reason why they've always, why they've been excited about the 15-year time horizon, not the kind of 3 years, whatever, is we understand the parameters driving this. Our medical loss ratio would have been 85%. We would have made money if the stabilization programs had worked as intended, if they hadn't played games with that stuff. We have a very different conversation probably now. Even it was a great conversation so far already, but that would have been another thing on it. And this year, or in 2017, we had a very important proof point on that. This thing called the medical loss ratio. Again, costs we have for medical costs divided by the premiums we get by our revenues. went from 120%, which was in 2016, that was our kind of like sad peak, to about 95%, which means we actually have an underwriting profits for the first time. And so the core insurance operations are now producing, are sort of like priced correctly now producing underwriting profits. We call it gross margin positive in the world of like tech and non-insurance startups, if you will. That was a very important proof point because to both have the growth we now had, we now have north of $1 billion in premium revenues for 2018, not plans, but in the bank because people have signed up already for 2018. And to couple that with a 25% drop in the medical loss ratio, I don't think many people thought was going to be possible. I mean, we had the biggest reinsurers, for example, bids on reinsurance contracts with Oscar. And several of those CEOs said, I think Oscar is more impactful than many other companies that I know of and can make huge change in healthcare. But I don't believe you can drop the MLR by 25 points. Well, it did happen, and we were able to do it. And we have a pretty straight line of sight from there to getting to the mid 80s or so now going forward as well. So long story short, they're very patient. They're very excited about this. When I first pitched this to Peter and Peter Thiel and Brian Singerman, the Founders Funds guys who put money in, it was funny because we were sitting there and Brian literally his head starts turning reds and he's so excited he starts scribbling on I think it was a napkin probably. He's like, I have this cancer company over here, I've got this EHR company over here, and he drew them all in kind of the circle. I'm like, I always knew the thing in the middle of the circle is missing. That's the insurance company because you got to connect all these other ones up, And so that's always been his long-term vision. I think on that point of view, I think we're in great shape there. One additional thing there, which helps investors as well, we have 3 very important partners for 2018 and beyond. Cleveland Clinic, Humana, AXA. They're all important in different ways. Cleveland Clinic basically realized, as a hospital, if I want to make money in the right way by having you be healthy so you don't come to the emergency room, as opposed to only treating you when you get sick and are in the ER, basically, I got to become like the insurance company. Collect premiums, invest in your health, and then make sure you're healthy.
Put in resources to keep you away.
Exactly. Well, not keep you away, I wouldn't say that, but
to
basically
keep you from having to come
keep you
in.
healthy.
Yeah.
Exactly. Or send somebody to your home if something goes on, stuff like that. And so they came to us after going to many other incumbents, many other companies, and said, let's launch a co-branded insurance plan, Cleveland Clinic Oscar insurance plan, where we share risk 50-50. So this is the first time this big clinic that has is number 1, number 2 in the US, every single, and probably the world from a quality perspective, says I will just really take risk on the costs I incur with managing this population, 50-50 with Oscar Cleveland. They're extremely powerful. That means they are really deeply in bed with how we do things.
Yeah.
If they didn't trust us paying claims properly, managing people's healthcare properly, understanding who people are and things like that, this wouldn't have worked. AXA did a so-called quota share reinsurance deal with us, where they also shared a bunch of our risk on their balance sheets, helps us with the regulatory capital and all that kind of stuff. Humana, co-branded plan in Nashville for employers, also 50-50. The fact that these extremely sophisticated organizations say, Oscar's got something I cannot find anywhere else, which is technology and member engagements, those 2 things. And I trust Oscar with how they do the work.
It's an
I think it's an extremely powerful thing. And that would not have happened 2 years ago. I mean, this is a big learning curve for us as well. But I'm glad it happened now.
All right, I have a couple of statements I want to put out there, and I want you to tell me if it's a myth or a fact. And some of them are connected, some of them aren't. Because you're technology driven, there's a lot of data, people can access the Oscar network through their phones. You are a millennial hipster insurer. Myth or fact?
Total myth.
Really?
Yeah.
You don't only have 26 to 35-year-olds? Do you have any 65-year-olds?
Yeah, we have plenty of them. So and it actually depends on where we are. In New York, we skew a bit younger, but that still only means we have about, call it 25% between 26 and 35 years old. The rest is over 35 years old. In Texas, San Antonio and Austin, 2 cities where we are quite big actually, about I'd say 50% of the population is over the age of 45, 50. So a much higher average age than we have in New York. and it's also lower income. So it really depends on where we are. And from the beginning, I really thought that both because it's the societally more interesting thing to do, but also because it appeals to me more as a complex problem. If we just insure, and no offense to people in the room, a bunch of Birkenstock wearing, granola eating freelancers in Brooklyn, then it's not that interesting. There's nothing interesting going on with them from a healthcare perspective. We should be insuring 65-year-old diabetics and who have complex issues and doing a good job with them. That's the issue in healthcare mostly. I mean, 5% of patients in healthcare drive about 65% of the costs.
Right.
And so if we want to get at the cost issue, which again is the biggest issue in healthcare,
you can't do it by covering healthy
millennials. You can't do it by,
millennials.
exactly. The millennials are important to stabilize the risk pool, though.
Right.
So you have to, if you don't have insurance, you got to buy it. If you want to vote in which direction the country should go without actually voting right now, you should buy insurance because it stabilizes the risk pool and makes it harder to mess with the regulations that I think have helped 50 million people to get insurance.
All right, well, speaking of regulation, Oscar is a tech company that benefits from more regulation rather than less regulation.
So I think that's a fact. I actually think that's a fact, and it's somewhat ironic, but I really think it's true. Insurance is a thing that doesn't work if you just get it when you're sick and you don't get it when you're healthy. It just doesn't work that way. You have to have some regulatory framework where we are all helped to make the right decision for our own long term, for society's long term, because you cannot control when you're going to get sick as much as you think you could. I mean, literally about I think 30-40% of healthcare outcomes is driven by behavior, and all the rest is genomics. It's whether you have the right physicians around you, bad luck, and things like that. And so there is regulation that's needed. We can have an argument about the right regulation, that's for sure, and. That also isn't as easy as it sometimes sounds. I am for high deductibles, and I'm for, these narrow networks we design, even though it's not entirely intuitive to the person who looks at this for the first time that
Right.
those are the pathways to go. But I can show you quantitatively, if you have 3 more hours, why it works that way.
And lots of data to look at.
Yeah.
All right, you mentioned Josh Kushner, so let's talk about this Kushner Connection. It helps more than it hurts.
That's a myth.
That's a myth.
That's definitely a myth. So, okay, it depends on what you mean with that, okay? There would be no Oscar without Josh, but that was before, his family started doing other things.
Has there been any concrete benefit from the Kushner Connection?
No, none whatsoever.
Publicity.
Yeah, but not in the good kinds, I would say. I think the low point in that was when we had an article that somehow connected Taylor Swift's to the administration. I think because Taylor is best friends with Josh's girlfriends and
Carly Kloss.
And Carly, exactly. Somehow that got mixed together in one big conspiracy theory.
And your name was in the story as well. Oscar Health was in there.
Exactly. So I didn't understand that one, but no, it really hasn't. It hasn't been a difference. We have been on Capitol Hill and talked to senators on both sides and House members on both sides. And show the data we have and basically say, look, if you give people the chance, they're going to buy a plan with a big deductible, higher deductible, because they kind of know better how they can manage that. They want to buy a different network design plan. They want to get the cost down. They want to get good healthcare.
Wait, was it Josh lobbying lawmakers?
No, it was Josh. Never been there. It was always we have a guy named Joel Klein on board who used to run the school system in New York, and he's chief policy and strategy officer, and was Joel and I basically going out there, and Bruce Gottlieb, our general counsel. The 3 of us are typically the people who go out and tell these stories basically, and. Again, it's a strange. DC is a strange place. I will not pretend to ever understand it. I think there's a lot more understanding behind, as I mentioned, behind the scenes. That this has done good for society. Nobody wants to take away insurance from people, and they're gonna somehow get there, I think.
All right. Final question before we open it up to the audience. Fill in the blank, Mario. If Oscar Health had to ask Josh Kushner to ask Jared and the White House for something, it would be blank.
It would be blank.
What about the $200 million that the federal government owes you?
That's not an administration thing.
They can help. They can help with the request.
That's in the courts right now, frankly. So I'm not sure the relationship is best there. So no, it's not the. It's just not. I don't think it's the way it works. And I really, really do think that what we have going for us is high word of mouth, different use of data and things like that. And I just don't care who's friends with whom to try to get that across. I have a super tight relationship with the regulators in New York, where there's no connection anyway, because they just really buy into
What you're
the
trying
stuff
to
we're
do.
doing, and
Yeah.
I think that's the way it works in the end. Yeah.
All right. Let's bring the microphones around so that we can open the floor up to questions for Mario. Does anyone have a question? Sir, in the front, can we bring over a microphone?
You mentioned that every subscriber of Oscar is paired with 4 members of the concierge. As you expand out to more and more clients, how does this model scale?
It scales, from what we can tell right now, quite well. The kind of PMPM cost we have, per member per month costs for running the concierge teams, isn't too different than the cost we have, or we would have if we had a general call center staff. Again, I think the reason is that from the beginning we were able to engage members very differently. Here's a good example. We are in regular conversation with 90% of our 10% most complex members. If you look at those 10% top cost members, 9% talk to us, on a very regular basis, which is very important because we can help discharge them from the hospital, make sure they get, medical equipment they need and stuff like that. Of those 90%, 60% talk to their concierge team through both chats and phone calls, and then 15% each only call and only chats, okay? So 75% basically are used to using chats, and that already makes a very big difference to be able to asynchronously help them, deal with them, get the doctors we have on board and stuff like that. So it goes back to what's very important about Oscar, which is from the beginning we thought we have to connect the dots well and build this as a full stack insurance company. If we outsource member services, if we outsource claims, which actually very early on in the history of Oscar, we had some of those things outsourced, network as well as I mentioned, it falls apart. And
You have to bring it back in.
Exactly. You have to really do this all in-house, otherwise there will be stuff lost in translation. You hate your insurance company when they tell you have to connect you with the prescription desk, whatever, or which time zone are they in, that kind of stuff. So it seems like it scales quite well. We made a big move in kind of mid-2016 to actually move that from New York, where it was all early on, in the PAC building where we have the headquarters, where it wouldn't have scaled, into Tempe, Arizona, where we now have a kind of operation center, and it's, I think, 400 people there or so now. And we have a lot more room to scale that there.
Thank you very much.
Gentleman over here, second row, right here. Thank you.
Yeah, you talked a lot about expenses in the healthcare industry, which I think we all understand. And Oscar's current size is relatively small to have strong influence on pricing in that industry. Are we expecting a method to just try to scale and get as many folks onto your platform as possible, or is there a potential that we could see Oscar integrate into the provider territory or the pharma territory or other aspects that are currently reaping a lot of that cash flow?
It's a very good question. I think this was an important question for us from the beginning. Do we have a chance of negotiating good unit costs when there is some correlation between how big an insurance company is and what costs it can extract from hospital systems and so on? One path that we could have taken as a company is to say, we'll just keep leasing a network and we'll focus totally on the experience. It's going to be totally white glove, and and you just overpay for that basically. And then the unit cost wouldn't have mattered as much. We chose, I think, the more difficult pathway, which for a while wasn't clear, I think, was going to work, and now I'm very confident it is working, which is now we got to build our networks, despite the headwinds of the size, not necessarily leading off the bats to lower unit costs. And again, the key there is these different network designs. The Cleveland Clinic now, for example, has a huge incentive to give us the most favorable rates they could possibly give, because half of the economics are going to be on them. Literally the way it works is we adjudicate the claims against the unit costs we have with them that we agreed on early on, and then whatever is left over at the end of the year, half of it goes to them. If it's a loss, half of the loss goes to them. And so that is a relationship where you really want them and where they will come with the best unit costs. And there are plenty of systems in cities across the US where you have 2 or 3 hospital systems competing in the city, where the systems are realizing, one way for me to win this, to kind of keep growing my business, is to keep jacking up rates every year. I mean, literally, there are contracts we used to have where you have an 8 to 10% automatic kicker in every single year. So the hospital costs just go up 8 to 10% every year. Which other industry exists that works that way? It makes no sense whatsoever. And it's not about a new technology. It's the same stuff going up 10% in inflation, basically. And so the smart guys, the smart hospital CEOs like Ken Davis in New York, guys like Mike Dowling as well on Long Island, they realized that the other way to win this is to build a more narrow network design around their facilities and physicians. And then you can also do another thing, which is you can have the physicians manage the healthcare better, right? Again, if you flip from fee-for-service into a narrow network, then you can go at risk, and you can share risk with the insurance company and things like that. And I think that's, again, as I mentioned, the thing that's going to play out. And for us, this is the places where we have no disadvantage. In fact, we have an advantage because Cleveland, for its parts, talked to all the incumbents and didn't trust them with being able to then give members a good experience in navigating that different network design. They thought members would go on network all the time, would have a bad experience, have to deny claims all over the place, and all these things. And so for us, you cannot build, and this is very important, you cannot build these different network designs, supply chains, if you will, without the member engagements, and you won't get the member engagements without the technology. And that's really the trifecta we have in a sense. These 3 things are inextricably linked. If you just look at the average insurance company's, again, websites, and don't take my word for it, there's a CMS regular study from literally 2 weeks ago, 45% of phone numbers in online directory of insurance companies are just basically wrong. And so imagine that and a selective network design. I mean, what are you going to be left with? Basically nothing. And that's why we have a big advantage there. And over time, when the flywheel spins, this is already happening now in some cities in the US, we are, 8% of the local hospital system's revenues now. That's big enough for us to now suddenly be in the driver's seat of the negotiation.
Let's go over here. This gentleman in the front.
So I love what you're doing with technology at Oscar. I was curious if the MLR ratio is capped at 85%. How do you get extra? How do you build your business model outside of that? And how do you warrant the tech multiples on your valuation that you're getting?
You're referring to the kind of lower threshold that the MLR cannot fall below?
85% is what you're capped at.
Yeah, exactly. That's an ACA ruling, basically, or rule that insurance companies cannot fall below a certain level of claims versus premiums. So the 85% is it'll be a while before we hit that. Not because we can't get there. I think we can get there, this or next year, but because you can count in the 85% even things like rewards we pay out. So there's a lot of ways for us to give money back to the members in ways that would be accretive to the business and to the brands and to the experience of the products that would not let us hit up against that thresholds. And the other, so that's sort of like a more technical answer. The other simple thing here is, in a very weird way, this is an issue for incumbent insurance companies where price doesn't flow through as easily to building a bigger business, which undoubtedly is the case in the current insurance markets. When you're a self-insured employer and your HR department negotiates the benefit designs with a benefit consultant who has a broker and all that middleman layer that's really does not add value in the healthcare system. I think that one I can say unequivocally, then very little of an insurer's business becomes about price. And the greatest example for that is that once you switched on the ACA marketplace, in the first 3 years, this Congressional Budget Office kind of projected out what the premium levels would be. And insurers came in 25% below that. And then eventually caught up. That was a big rate increase from 2016, 17, and 18 now. Now they're sort of like where the CBO thought all along, 5 years ago, the rates would be. And why is that? Well, because those prices were on the websites, and you could look at them. And because individuals pay out of pockets, insurers realized, oh shit, pricing actually maybe matters. And so, long story short, if you're in a market that we are in, individual markets, small employer markets, price matters a lot more. And so if we were hitting up against the lower thresholds, and we would basically then simply say next year, great, prices come down 10%, right away, volume would increase, we get a bigger market share, and that's flywheel would spin for a long time. So I don't see that as I really don't see that as an issue. I think it's a positive for everything. Yeah.
All right, final question. Let's go over here to the woman in the front row.
Thank you. Hi, Mario. My name is Lauren Koenig, and I was just wondering, since the inception of Oscar Health, what's the biggest thing that you're most proud of overcoming, maybe even on a personal level, that most people don't know about?
Yeah. I think, I do think it is I'd say it's the organizational stability we've had. You know, we, in many ways, had the perfect storm of like stuff happening to us. So we had a person getting elected who wanted to kill the market we're in, purposely and rhetorically. We had that was the year we had the worst medical loss ratio. The market was already unstable. All these things happened at the same time, basically, and yet somehow, nobody left Oscar over that. I think, if anything, Joel Klein gave a rousing speech on the day after the election. He's a guy who's been around the block for decades, really, right? Was in the White House and working Bloomberg and so on, and sort of like reminded people of what it is that we're doing and why it's important, and that again, we have it to some degree in our own hands, whether this markets is a market that people feel a need to keep stable and keep around, basically, by just building a better product. And the fact that people stuck with us in the organization, I think, is, to me, is the thing I'm most personally proud of, in a sense. And it's not just because I somehow give great speeches in the all hands meetings every week, whatever else, but I do think it's because of the mission we've had, and then the luck we've had that we were in this at the right time. And again, as I mentioned, if Josh and I had talked about this in 2011, would have been too early to raise money against the ACA coming out. If it was in 2013, would have been too late to launch into the ACA. It was just around the right time. So I think I wouldn't say it's well known that was a, you got to keep the organization, team together, but that it happens, I think, is powerful to me. And on a personal note, I think it's the fact that I have 2 kids, and that they kind of grew up as part of Oscar growing, and with my wife being very understandable of sometimes long hours and stuff like that. And that all kind of works. That was just a thing I'm grateful for.
And everything they're going through is a case study for you to build off of.
Definitely everything. I used to, whenever I demoed Oscar, which happens probably like 5 times a week or so, for hospital people, physicians and investors and so on. I used to only use my kids' health history. They had like the tonsillectomy and whatever. Now they're getting too old, and so I got to use my own.
Mario Schlosser, co-founder and CEO of Oscar Health. Thank you very much. And